Hi everyone, and welcome back to another Corsmed MRI video. In today's video and topic and protocol, we're going to do the shoulder. But specifically, we're going to do the shoulder with the clock face method. We're going to do so start to finish inside the Corsmed MRI simulator. So let's go. Here is the Corsmed MRI simulator, which is the tool I'll use to walk you through the shoulder protocol. In MRI, there are three core trade-offs: scan time, resolution, and signal-to-noise ratio. When we improve one of these, the other two become worse. So how should we balance these metrics when it comes to shoulder MRIs? Since the shoulder contains fine critical structures like the labrum, tendons, and cartilage, we need very high resolution. We also need strong SNR to compensate for this high resolution so that we maintain good image quality. While we try to keep scan time reasonable, having clear images is more important to accurately diagnose the shoulder. Therefore, you may want to slightly prioritize resolution, followed by SNR, and lastly scan time. This ensures we can see small tears and subtle pathologies clearly. Now, what medical conditions are we looking for in shoulder MRIs? First, we have rotator cuff tears, labral tears, and slap lesions. These show up best on PD fat-saturated sequences, which enhance soft tissues and fluids without fat signal interference. Any tears will appear as bright signal that interrupt the normally dark tendon or labrum. Next, we look for avascular necrosis, fatty infiltration, and bone marrow changes. These are clearly seen on T1 weighted sequences, which highlight fat, bone structures, and help us see the overall anatomy. Finally, we check for bone marrow edema, joint effusions, and adhesive capsulitis. These conditions are best seen on T2 weighted sequences, which highlight fluid-related abnormalities and edema. Now, let's begin by reviewing our hardware settings. We've selected a shoulder coil array, a dedicated coil that surrounds the entire shoulder region. Some MRI systems can also work with flexible coils. Either way, the coverage must be sufficient to ensure strong signal quality. We're working with a magnetic field strength of 1.5 Tesla, and we also use a maximum gradient strength of 45 millitesla per meter. This setup balances acquisition time, image quality, and patient comfort, and is widely used in clinical practice. Let's now place our three plane localizers into the viewports. From left to right, let's place the axial, sagittal, and coronal planes. We'll scroll to a central slice in each view to ensure good signal across our shoulder region. Now, there are several strategies to run a shoulder protocol. Today, I'll show you the well-known clock face method. The shoulder joint has a very complex three-dimensional anatomy with structures like the labrum, rotator cuff tendons, and joint capsule all packed together. This anatomy can make it difficult to describe exactly where issues are located using traditional terms like anterior or superior. The clock face method is a way to solve this communication problem. With this method, we imagine looking at the glenoid, the socket of the shoulder, from the side, like looking at a clock on the wall. 12 o'clock is at the top, 3 o'clock is to the right, 6 o'clock at the bottom, and 9 o'clock is to the left. For example, instead of saying a labral tear is in the anterior superior region, we can say it runs from 1 to 3 o'clock. Or if there's rotator cuff damage, we might say it's located at the 12 o'clock position. This precision helps surgeons know exactly where to look and what to repair. Now, the initial localizers we placed here show the shoulder in a neutral position inside the scanner. We'll also need a second round of localizers to plan our sequences according to specific anatomical structures. To get these localizers, we'll first add a two-plane localizer sequence in sagittal and coronal views. This gives us clear visualization of the glenoid, fossa, and rim. Second, we'll add an axial fast spin echo sequence as a localizer. This helps us see the supraspinatus tendon. Let's plan our sagittal and coronal localizers first. Since these localizers give us a good view of the glenohumeral joint, we'll use the glenoid rim to angle our slices. You can see it clearly shown over here. Now, the sagittal and coronal localizers typically share the same center. The sagittal slices run parallel to the glenoid rim, as shown here across this region. The coronal slices instead run perpendicular to the glenoid rim, also shown over here. Both localizers will run within the same sequence. Let's now save and run these pulses. Now that the sequence has finished, let's have a look at our images. Looking through the sagittal localizers, we need to check that the glenoid fossa is well seen. You can see this structure over here. This round area will serve as the face of our clock reference. Here we can see the structure clearly, and also the coracoid process just above it. Now let's drag and drop this same sequence into another viewport so we can scroll to the coronal slices. In this plane, we'll focus on the glenohumeral joint. Specifically, we will focus on the upper and lower points of the glenoid bone. Here you can see the upper point, and the bone goes all the way down to this point over here. Now that our sagittal and coronal localizers are ready, we can start working on our axial localizer. This axial will be a turbospin echo sequence with proton density and fat suppression contrast. Let's review the echo and repetition time to make sure we have a proton density weighting. We're also applying a spectral fat suppression pulse to null the signal from fat. This gives us good visualization of the supraspinatus ligament, which is crucial for planning our high-resolution sequences. Now let's work on our coverage. We need enough slices to cover the shoulder joint and our area of interest, the supraspinatus ligament over here. We can also angle our slice package so it's perpendicular to the glenoid bone tips. Let's fine-tune the angle now and center our slices. Finally, for image presentation, we can adjust the field of view and axial position for a straight view of the shoulder. Let's center our field of view over here. These localizer sequences take only about 2 minutes in total of the entire protocol. But while they are quick to run, they are very important for planning our real sequences. So take your time to set up your localizer sequences carefully. We can now save and run this axial localizer. Now that the axial localizer is done, let's look through the slices to review it. The shoulder position can be difficult for patients to stay still in. So make it a habit to check your slices to make sure there's no motion. Now let's check our supraspinatus ligament, which we can clearly see over here as a dark trim. This structure will help us acquire our high-resolution coronal plane. Now let's move on to add the high-resolution sequences for the shoulder. Using the clock face method, we'll run a standard protocol that includes 3 planes, sagittal, coronal, and axial, in proton density fat-suppressed contrast. We'll also add a sagittal T1, a coronal T2, and an axial T1. Protocols may vary from one medical center to the next, so always follow your particular guidelines. Now let's add these sequences to our protocol list and get started with the sagittal proton density Fat-Sat sequence. It's very important to get the order of sequences right to succeed with the clock face method. Each sequence helps us plan the next one. For the sagittal plane, let's set the position over the corresponding localizer and center our field of view. Next, on the coronal localizer, we need to align the slice parallel to the tips of the glenoid bone. Let's zoom in so we can see the upper and lower tips of the glenohumeral joint. We'll run the slice parallel to these structures. For the axial localizer, we typically follow a parallel orientation to the glenoid rim. Once again, let's zoom in to adjust the slice angle just right. Here we have the glenoid rim, so let's angle to be parallel to that structure. Moving on, let's set a high spatial resolution for our sequence. We'll use 3 mm slice thickness and 0.3 mm slice gap. We also need to add enough slices. In this case, 29 slices will cover from the deltoid muscle to the scapular notch. Let's now center our slice package and field of view. Here, let's center our field of view. Next, let's check our parameters. We've set up echo and repetition times to give us a proton density contrast. We also have a spectral fat suppression pulse to nullify signal from the fat. And we have an appropriate turbo factor or echo train length for this selected echo time. Before running our sequence, let's make sure the spatial resolution and acquisition time are good for image quality. We're ready to run these pulses, so let's save and run. Let's look at our Sagittal PD Fat-Sat sequence. We need to check for high signal and resolution, as well as no artifacts. On this sequence, we see excellent quality of the glenoid fossa over here, nicely outlined. You can also see the coracoid process over here. These are really good images to now plan our coronal proton density Fat-Sat view. Let's start by setting our field of view position on top of the coronal localizer. The angle on top of the Sagittal PD Fat-Sat will follow our clock face approach. We'll orient this from the 12 o'clock down to the 6 o'clock positions. Zooming in here, we can see the 12 o'clock position at the top and the 6 o'clock position at the bottom of the glenoid. Let's adjust the angle to connect these 2 points. We'll also center it. On the axial localizer, there are 2 ways to angle our slices. The standard way typically needs perpendicular angulation to the glenoid rim, as shown over here. This gives clear views of the articular surfaces and labrum. However, I strongly recommend that you align your slices parallel to the supraspinatus tendon, as shown over here. This gives you an exceptional view of the rotator cuff ligaments. To get a high resolution, let's set a slice thickness of 3 mm and a slice gap of 0.3 mm. We also need enough slices to cover our shoulder region from side to side. Let's use the 3 viewports to center and adjust the position of our coronal slices. We'll run the slices in our axial and sagittal views to cover from the front portion of the coracoid process to 2 slices behind the humeral head, as shown over here. Now that our field of view is centered and positioned, let's review the parameters. We have set an echo time and repetition time for proton density contrast. We also use spectral fat suppression and a turbo factor that works with our selected echo time. Since these parameters are similar to our previous sagittal sequence, the resolution and acquisition time are also good. Let's save and run this sequence. Now that our coronal plane is ready, let's review the image quality and angulation. We've got excellent quality. Here we can see how the supraspinatus ligament is displayed throughout its length in just one single slice. We're ready to move on to plan our last sequence, the axial proton density Fat-Sat. Let's first set a perpendicular slice position on top of the coronal plane. We'll set slice thickness to 3 mm and gap to 0.3 mm once more. The number of slices should cover from the top part of the acromioclavicular joint, shown over here, down to 2 slices below the articular capsule. Now let's use the glenoid rim once again to angle our slices correctly. Notice how we use our previous high-resolution images to help us angle the following ones so we get a perfect angle. Now let's center our package and move to the sagittal sequence. Here we'll refer back to the glenoid fossa as the face of the clock. This angulation will be oriented to the 9 to 3 o'clock position of the clock. So we're drawing a line from left to right across the glenoid. This shows you why the sequence acquisition order is really important. Lastly, let's position the field of view box on top of the axial plane to have a straight view. You can see that the slices are skewed on the coronal and sagittal sequences. Don't worry, that's because the oblique angles of the shoulder are challenging. I strongly recommend following these steps and you'll definitely succeed. Now let's review the parameters. This echo time and repetition time are correctly set for proton density contrast. We're using the same spectral fat suppression pulse as before and a turbo factor aligned for high image quality. Resolution and time are set just right. We can now save and run this axial sequence. Now, all our 3 planes in proton density with fat suppression contrast are now done. Let's take a few minutes to review them. First, let's check that image quality in our axial images matches our sagittal and coronal sequences. These look very nice. The axial proton density Fat-Sat sequence improves detection of subtle tendinosis as well as labral and capsular pathologies. These are all critical for accurate diagnosis and treatment planning. Let's take a close look at the labrum, which we can clearly see over here. This appears as a small black dot. We need high spatial resolution to see these structures clearly. Looking at the ligaments, we can see the infraspinatus tendon over here. We can also see the subscapularis and superior glenohumeral ligament structures. They're very well seen, with complete coverage all the way up to the acromioclavicular joint, shown right over here. Now, the coronal plane captures shoulder anatomy in the plane of the rotator cuff. This view gives radiologists a complete look at the soft tissues. Here we can clearly see how the biceps tendon runs in one single slice. Let's zoom in and see how it extends all the way here. Radiologists typically prefer the coronal view to explore the glenohumeral joint. This view helps us spot both bone marrow edema and cysts. The sagittal sequence lets us see the shoulder from a different angle that complements the axial and coronal planes. This gives us a detailed view of muscle quality, tendon insertions, and joint structures. We can clearly see the supraspinatus, infraspinatus, and subscapularis muscles in cross-section, which is really important for checking muscle health, tendon retraction, and glenoid morphology. Now that we've got high image quality and planning for the 3 planes, let's work on our sagittal T1 sequence. We can copy the slice planning and geometry parameters from our sagittal PD Fat-Sat. This copy feature is common in MRI systems nowadays, so let's right-click on our sagittal PD Fat-Sat sequence and copy all slices into our sagittal T1. We will keep the identical planning and only review the parameters. An echo time of 10 milliseconds and repetition time of 400 milliseconds work well for T1 contrast. The turbo factor is set to 2, which fits well with our selected echo time, and the acquisition time and resolution of this sequence are also ideal. We can now save this sequence. Let's carry on with the coronal T2. We'll similarly copy the slice planning and geometry from our coronal PD Fat-Sat. Now let's verify the image contrast. A relatively long TE and TR will give us T2 contrast. The turbo factor is adjusted for this echo time to optimize our scan time. We also have a high signal and resolution. So let's now save this sequence. Finally, let's copy the prescription from the axial PD Fat-Sat into our axial T1. These short echo and repetition times will give us a T1 contrast. We also have an optimized turbo factor that helps shorten scan time. Together with the other parameters, this gives us excellent image quality. Now let's save this sequence and run the last 3 sequences together. Our T1 sequences are now done, so let's start by reviewing the axial and sagittal ones. T1 contrast is crucial for checking anatomical structures and fat content. In diagnosis, this contrast helps identify bone marrow pathology fatty infiltration, and muscle atrophy. Always take your time to review image quality of your acquired sequences. Now let's look at our coronal T2 sequence. T2 weighted images are highly sensitive to fluid. This makes them really important for finding edema, inflammation, joint effusions, and tendon tears. We've got exceptional image quality for this coronal T2 sequence. There's an interesting phenomenon known as the magic angle artifact. This artifact shows increased signal over the tendons, which happens when we use echo times around 30 milliseconds. That's why we need T2 weighted images to confirm if this artifact is present or if there's real inflammation in the tendons. The complete protocol takes about 20 minutes to get excellent image quality. With that, we will wrap up this video tutorial. I hope you have now gained greater confidence in how to perform a shoulder MRI protocol. To recap, here are the most important takeaways to remember. First, we generally prioritize resolution and signal-to-noise ratio over scan time for shoulder MRI. The shoulder has many small critical structures like the labrum and rotator cuff tendons, so we need very high resolution to see subtle tears and pathologies clearly. This high resolution, however, will reduce our SNR. So we need to push our SNR back up to keep our images clear from noise. While we try to keep scan time reasonable, image quality is more important for accurate diagnosis. Second, we use the clock phase method with specific sequences for shoulder imaging. The 𝗬𝗏𝗏 serves as our clock phase to ensure we angle our slices consistently. For sequences, we mainly use proton density fat saturated sequences in 3 planes, plus T1 and T2 sequences. Proton density Fat-Sat gives us excellent soft tissue contrast and highlights fluid. T1 shows anatomy and bone marrow, while T2 is sensitive to edema and inflammation. The order of sequences is very important. Each one helps us plan the next for best visualization. Third, make sure to avoid the common artifacts that can arise from the shoulder region, which include motion, magic angle, wraparound, chemical shift, and susceptibility artifacts. Some techniques we can use to avoid these artifacts are to ensure proper padding and positioning for patient comfort, use appropriate echo times, especially for T2 sequences to confirm real pathology versus magic angle, use large enough field of view, increase the bandwidth, and use turbo spin echo instead of gradient echo sequences. If you cover all these 3 points, you will be able to perform excellent shoulder MRI protocols. Thanks for joining, and I will see you in our next session.